All right, I'm back for the sixth and final installment of my Overdose series. And today we're going to talk about proven and potential solutions to the overwhelmingly tragic drug epidemic that's ravaging our country, killing hundreds of thousands of people every year and debilitating millions more.
Somebody get this guy some help!
Now, some of the proposed solutions have a lot of evidence and logic behind their uses, but oftentimes social factors and considerations can get in the way of communities accepting a different way of approaching this problem. Oftentimes, there is a huge stigma that other people or other families struggle with addiction. And sometimes it takes a direct experience with a loved one dying or becoming functionally impaired as a result of their addiction to destigmatize it. People who struggle with addiction ultimately can be viewed as lesser than, limiting the number and availability of some of the resources that we'll discuss in today's episode. The reality is that we're all addicted to something, whether it be an illicit drug or substance like meth, heroin, pain pills that runs the risk of dying with each use, or a licit substance like nicotine or alcohol or benzodiazepines, in some states, marijuana, prescription medication. Some people are addicted to their phones and diverting attention away from their internal experience. Some people are addicted to power or sex or money or greed. These are all things that ultimately make us feel better in the moment or in the short term, but limit our ability to move towards the things that are ultimately meaningful or important or valued to us in the long term. All that to say, we're way more alike to each other than we are different. To speak to that fact is the data showing that nicotine and alcohol kill way more people on an annual basis than the other drugs we've discussed, though most of these are chronic deaths from accumulated medical comorbidities and are not associated with as many years of life loss. The other drugs in brighter red colors are drugs that can kill instantly via overdose and have been the focus of this series. Um, so when I graduated from high school in 2007, I didn't know what was afflicting my classmates. I was not aware of this problem, but learned through the next decade that I lived near the epicenter of the drug epidemic. I saw football players, cross country runners, mathletes, and advanced program students, people from different walks of life, all getting addicted to opiates primarily, and subsequently other drugs. This is a problem that as a society we've got to destigmatize. Naturally, more people being affected should lead to more empathy and sympathy for those afflicted, but hopefully it doesn't take a majority of our nation to suffer the fallout to have compassion for this population. Um, One of our basic approaches that we need to adjust in our medical training and within outpatient services and in the emergency rooms is how we view addiction. It is a chronic disease. It needs to be looked at as a chronic disease. And just like we would do what we could to optimally treat a hypertensive patient with high blood pressure or a diabetic with high blood sugar, regardless of how compliant they've been with treatment or how we feel about how they're living their lives and the choices that they're making, we should be doing the same with addiction. We need to offer all forms of treatment, from primary prevention to tertiary. Take an approach of offering preventive treatment, giving acute treatment, chronic treatment, and also maintenance treatment after the person has achieved meaningful recovery. Um, Now, words certainly matter in this discussion. And this piece isn't meant to make people resistant or feel uncomfortable. It is a way and a slide that is emphasizing the fact that we need to humanize the struggles that people in the throes of addiction face. One prime example of that is in the word abuse or drug abuse. Now, let's take a parallel where the word abuse is used appropriately in reference to domestic or child abuse. In those situations, the child, for example, is being abused by an abuser. And there is a very negative connotation associated with the word abuse. Now, with drug abuse, if you follow the same line of thinking, it seems that a person is abusing a given substance and carries with it this connotation of punishment rather than treatment, when in reality, the drug is abusing that person and their health, not the other way around. Similarly, the term addict dehumanizes somebody. It insinuates that they are nothing more than their addiction, throwing out their positive qualities or the negative or traumatic life experiences that contribute to their struggle with the disease of addiction. It also indicates some sense of permanence in that condition, that it is static and inherently part of who they are without a likelihood of change. So words are critically important in those first few minutes of approaching someone suffering from an addiction. Um, so look, it's hard to get ourselves, much less others, to change their behaviors. There certainly must be internal motivation on the patient's part and a willingness to experience some discomfort along the way. But we cannot just focus on the individual approach. Our approach to addiction must address all aspects of social, psychological, and biological function. We need to understand the system that promotes addiction and work on every aspect, from the individual's perspective and what they feel to the interpersonal impact and how their addiction affects those people related to and in regular contact with that individual, positively or negatively. We need to address the community changes and concessions that must be made to reduce the taboo surrounding addiction and build these individuals back up, as well as revamp our societal approaches to addiction, incentivizing insurance companies to provide more coverage, promoting educational and prevention programs, and maybe most importantly, change our policies of law enforcement, demonizing drug use. The most relevant and harmful societal approach, in my opinion, was the quote unquote war on drugs, which really represented a war on drug users, incarcerating and punishing those affected through the 1970s, 80s, 90s, and this still persists today. We've got to help people reestablish their basic social and psychological needs, not just rely on medical or biologic treatment to help them improve. It simply will not sustain them in their recovery in terms of the masses. People need to be reintroduced to and feel support from their communities. And if they don't have one, help them to find a community. Um, so let's start talking about some specific solutions. And we'll do so kind of starting with retracing the first wave of this evolution of the epidemic. So it all started with an increase in the prescribing of addictive substances, which, by the way, we're still prescribing as many or more opiates, benzos, and stimulants today as we were at the peak of the prescribing epidemic. So this 2019 University of Michigan study is of 130,000 post-surgical patients in 3 countries, the US, Sweden, and Canada. These are all for minor surgical procedures. And what they show is that American post-surgical providers are 7 times more likely to prescribe an opioid within a week of discharge compared to Sweden. And our average morphine equivalents that are prescribed after these surgeries are also significantly higher than both Sweden and Canada. And as you can see, Canada also is falling into the same trap that the United States has in terms of really over relying on medication and not considering that long-term risk, more so just considering the short-term reduction of pain and symptoms and likely getting a little bit better patient satisfaction score because of that short-term reduction or short-term helping the person get away from that uncomfortable feeling. But again, at the expense of long-term recovery and stability. We in the United States routinely prescribe, on average, 3 to 4 times the recommendations that you see on the right, which take into account the potential for addiction to develop with an outpatient prescription. Now, why is this important? Well, because what's revealed in this data set and others is that the 1 year and 3 year probabilities of continued pain pill usage among people who had never taken a pain pill until they were prescribed it post-surgically increases drastically past a short-term 5-day outpatient opioid prescription. The risk of continued use at 5 days is a little bit less than 10% at 1 year, which is still significant, and a little bit less than 5% at 3 years. But for somebody who is prescribed a 30-day supply, which is the most common prescription length, it reveals a risk of nearly 40% of continued use at 1 year, 20% at 3 years. Even the risks of 1 year and 3 year use after 5 days are still 10 and 5%. I must point out again that these medications desensitize the patient's pain receptors to the perception of pain. When they wear off, it's like having the numbing medicine at the dentist wear off, a gradual increase in the perception of pain until that opiate is completely out of the system. Long-term use of opiates and opioids cause what is called hyperalgesia in the long term, or a increased sensitivity to pain. They do not continue to work well for most people with chronic pain in the long term. Similar to most people with chronic anxiety in the long term on benzos. They change people's brain to desire more of the addictive drug and alter their behavior progressively over time. So opiates are in an important class of medications. Have they done more harm than good as a whole? I absolutely believe that. But do they have a legitimate medical purpose? Absolutely. It's really important that we restrict those initial prescriptions to the minimum amount needed to help post-surgical patients have early mobility to improve to as close to their pre-surgical baseline of functioning as possible. These are some very straightforward examples of ways to talk to patients about these risks and minimize their risks of cultivating a lifelong addiction after having a minor surgical procedure like a knee replacement or a breast augmentation. So education is paramount for prevention and to set the next generation straight in terms of knowing all of the associated risks and the lack of long-term benefits of these substances. But right now, we also have millions of people who are beyond the prevention stage that need help now. They've moved beyond just prescription pain or anxiety pills to using illicit substances. And after the emergence of the second wave of the epidemic involving heroin, a lot of people started using drugs intravenously. Now, what's the definition of insanity? Well, it's doing the same thing over and over again and expecting different results. We've got to start doing things differently with how we approach addiction and illicit drug use. demonizing and incarcerating this population, or shaming them into changing, or offering an abstinence only form of treatment. These are clearly not working. So maybe we should try something different. Maybe we should shift our focus to reducing harm, meeting users where they're at, and clearly showing compassion to this population. Um, First and foremost, we can't help people if they're dead. So continuing to increase access to Narcan or naloxone, an opioid antagonist that prevents opioids like Oxycontin and fentanyl from binding to the opiate receptors and causing the downstream effects like slowing and stopping breathing, leading to death by hypoxia or not breathing, is vitally important. Narcan can be administered intranasally by inserting it deep into somebody who is overdosed nostril and pushing the lever to hopefully reverse the overdose. Sometimes, due to how powerful and potent fentanyl's effects are, you may need multiple administrations. The actual dose in each Narcan has increased drastically in the last several years due to the increased potency of opiates in our environment. Because Narcan kicks fentanyl off the opiate receptors, don't be surprised if the overdose person comes back to consciousness and is irritable or angry. The last thing they remember is being high and euphoric. They didn't consciously experience the slowing or even stopping of their breathing. Um, Next thing you know, you're waking them up and they're thrown immediately into opioid withdrawal. These reversal agents that don't produce any sort of euphoric effects need to be much more widely available in gas stations, convenience stores, obviously in pharmacies and health centers, et cetera, at an extremely cheap, if not free, cost. I always tell my patients who don't struggle with addiction, pick up a 2-pack of Narcan because it would be a shame to have the chance to save somebody's life but not have the reversal agent on hand. So before we get to some a little bit more polarizing issues, let's discuss another one that's pretty uniformly agreed upon as a protective measure in treating addictions and so important with the amount of contamination in our drug supply. That's the use of FTSs or fentanyl test strips. So these are straightforward, right? People who are using any substance because of the amount of contamination in every illicit drug um, can use this to decipher beforehand if there's any fentanyl in it, which is the main cause of people dying in overdoses. So there was a study of 93 young persons who inject drugs that were given fentanyl test strips in Rhode Island. They had 81 that returned for follow-up, and of those 81, 62 had used at least one fentanyl test strip, with half of them finding fentanyl in their drug supply at least once. Of all 81 participants that used fentanyl test strips, 79 out of 81, or 98% of them, reported confidence in their ability to use them, and 77 or 95% wanted to use them in the future. Another North Carolina study found similar results, with 81% of 125 people who inject drugs being willing to use fentanyl test strips. 43% of them reported positive changes in their drug use, and 77% felt an increased sense of safety by using them. Now, if you are using drugs intravenously, and in one scenario, you're chased down, arrested, and taken to jail for using a drug where you may go into full drug withdrawal, even when you're not harming anybody but yourself, versus the second scenario where a nice person goes out of their way to help you reduce risks associated with drug use. They show compassion instead of judgment and being derogatory and dehumanizing. Which one do you think is more likely to lead to your recovery? Look, I'm not saying that everybody struggling with addiction can be helped. But I think it is my job, it is our job to try to help everybody. But this is just such a common sense and simple way of reducing harm in this population.
All right, now let's stir up some controversy and talk about a couple other harm reduction measures: needle exchange programs and overdose protection centers, also known as supervised injection sites or facilities. According to 2022 CDC data on syringe services programs, as well as a 2014 International Journal of Epidemiology article on rates of HIV transmission, as well as another 2017 HIV prevention study, these needle exchange programs where somebody injecting drugs can go and give their old needles, all their used needles, as well as get new, fresh, unused needles, led to a nearly 50% local reduction in HIV transmission. We'll look at Portugal's situation in a little bit, a country that has legalized and regulated, decriminalized all drugs, and how that has impacted a huge reduction in Portugal's HIV transmission. But not only does this create a clear and logical way to reduce the transmission of infectious viruses like HIV and hepatitis C, it also brings users in contact with healthcare workers and public health workers on a regular basis. They can hand out education on how to further reduce harm. They can provide access to adequate medical care. They can give condoms, other forms of STD and pregnancy prevention out. They can, recommend, again, medical assessments when needed. But every time that somebody interacts with these systems or programs, it's another chance for them to be convinced to seek out more intensive treatment for their addiction. Now, this harm reduction strategy, supervised injection sites, overdose prevention centers, probably sounds a little bit better. It really gets people up in arms, but it has evidence of being more effective in the long-term reduction of harm and overall illicit drug use. OPCs, which were initially called supervised injection sites or facilities, can be really helpful in our fight against this drug epidemic. This picture that you see here is one of two recently opened overdose protection centers in New York City by a nonprofit organization called On Point. It allows people to use their drugs using a checklist to notify the available providers of what they're using in case they have complications. It represents an alternative to using on the street, the sidewalk, between cars, under a bridge, in other unsafe areas. And it also allows somebody to use and not break my number one rule of safer drug use: don't use drugs alone. These OPCs, or supervised injection sites, have existed around the world for a long time. Several past studies have shown that they improve local outcomes. They reduce local overdose deaths. They reduce healthcare costs. They reduce the use of emergency rooms and subsequent hospital stays, reduce public drug use, infectious diseases from non-sterile needles, reduce the amount of unused syringes or used syringes that could litter and theoretically infect a non-user not paying attention, that takes a wrong step, probably while entranced by their device on their way to work, on their way to dinner. These facilities also provide testing for the drugs prior to use and ensure clean needle use and appropriate skin cleaning prior to the injection, reducing theoretically the risk of endocarditis or heart infection. These sites have shown promising results in major metropolitan areas for nearly 25 years, with Vancouver, Canada's Insight, one of the first in the world when they opened in 2003, showing a 35% reduction in fatal overdose rate over 4 years in areas within a quarter mile of the site, compared to a 9% reduction over the same time period in the rest of Vancouver. In Sydney, Australia, at one of their supervised injection facilities, the number of monthly ambulance calls related to overdose decreased by 80%. Importantly, none of the studies in a major systematic review of these centers showed any overdose deaths. San Francisco facility that was open for a little less than a year until unwarranted public backlash shut it down showed that over 10,000 drug injections, only 33 opioid-related overdoses occurred on-site. All of those were reversed with naloxone or Narcan, with nobody dying and nobody even having to be transferred to a medical facility. Contrary to critics' beliefs, there were not increases in crime, there was not increases in total number of persons using drugs, or in drug use-related public nuisances. There were positive associations of visiting the site with a 1.4 to 1.7 times increased likelihood of the person using entering a detox program or an addiction treatment program compared with those who use drugs but visited overdose protection centers either infrequently or not at all. And the bottom line is, we don't view things like dialysis, which is essentially an external kidney that people rely on when their kidneys fail. We don't view dialysis the same way as addiction. Even though that condition, like most other major medical conditions and complications, oftentimes have a component or sometimes are directly tied to poor lifestyle choices. We don't restrict treatment. We don't shut down dialysis centers because patients are not abiding by their doctor's diet and activity recommendations or not taking their medications, nor do we do that with other chronic diseases. Why should addiction be any different? Next on the list of harm reduction measures is another hot topic, the use of MAT, or medication-assisted treatment. So while Vivitrol, or naltrexone, which is a monthly injectable version of naloxone or Narcan, is a very viable and an ideal MAT option for opioid use disorder that severely limits the potential for fatal overdose, most opioid users know that it will send them into withdrawal. They may not be willing to engage with treatment via this route. Vivitrol or naltrexone is a direct opiate antagonist. It will kick off other opiates occupying those opiate receptors and send the person into withdrawal. Again, very safe. There's no opiate in it. It's an ideal option, but it may not be something that the patient is willing to do. And that's where other medication-assisted treatment options come into the fold. The most well-known historical opioid MAT is methadone. However, I'm not a huge fan, and I'll tell you why. Methadone is what's called a full agonist at the opiate receptors. People regularly fatally overdose on methadone by itself, with more than 55,000 deaths between 2007 and 2021. According to an addiction research retrospective administrative data study in England and Wales, assessing nearly 20 million MAT prescriptions of methadone or buprenorphine, aka Suboxone, or one of the two components of Suboxone. So 20 million MAT prescriptions and 2,400 deaths in a 6-year period between 2007 and 2012. There were 2,366 methadone-related deaths and only 52 buprenorphine-related deaths. Now, there was a lot more people on methadone than buprenorphine, but still the relative risk of death on those medications was 6 times higher with methadone than it was with buprenorphine. Methadone may be more effective at keeping patients in treatment, potentially because buprenorphine has what's called a ceiling effect, which we'll discuss in a second. But I think the risk overall is much higher with methadone. And buprenorphine is, in my opinion, the much safer option. Or better said, Suboxone, the combination of buprenorphine and naloxone, is a much better option. In a Marion County, Indiana study, which includes Indianapolis, of nearly 2,400 overdose deaths, only 55 involved buprenorphine, and of those, 51 of them had heavy involvement of other illicit drugs. And remember, benzodiazepines are one way that buprenorphine can kill people if it is combined with a benzo. The 4 other deaths were attributed to buprenorphine and liver failure or diabetic ketoacidosis. Benzos were present in 24 of the 55 buprenorphine-related deaths and fentanyl in 51% of them. And this is the reason why Suboxone is safer. Buprenorphine is a unique opiate because it's what's called a partial agonist at the opiate receptors. What that means is it limits its ability to cause respiratory depression. Again, that may go out the window when it's combined with a benzo. But therefore, the overdose on buprenorphine by itself will not stop someone's breathing because of this sealing effect. Only occupying at most a little bit more than 80% of opiate receptors and blocking the others from being bound by fentanyl and other opiates. Therefore, they won't die from just their medication-assisted treatment alone. And if they slip up and use something like Oxycontin or heroin or fentanyl, or has something with fentanyl in it, it will not have an effect because it's blocked out. And then those other opiates are eliminated without the person feeling the high from it, or more importantly, running the risk of dying from it. The inactive naloxone component is only in there if the person tries to melt the drug down and inject it, activating the opioid antagonist portion of naloxone. Now, as with everything on this podcast, I try to appreciate the nuance and offer both sides to the stories I tell. So there is a dark side to Suboxone. For one, because it binds so strongly to the opiate receptors and doesn't allow fentanyl and other synthetic opioids to bind, even when it is inactivating an opiate receptor, this means that Suboxone has a nasty withdrawal. Similar to the stickier a Band-Aid is, and the longer it's been attached to your skin, the more it's going to hurt when you pull off. So coming off of Suboxone has to be done carefully and ideally slowly over time. But the risk of dying for somebody injecting drugs or using fentanyl is extremely high coming out of a treatment program. So this medicine certainly has utility. But the other factor that goes into this conversation is to have an appreciation for how a business person and the business side of Suboxone can operate at many of these recovery facilities. There is a lot of money and a consistent monthly patient population to be had in the field of addiction. You are replacing one addictive substance with a much safer but still somewhat addictive substance, and mandating that the person be seen every 2 to 4 weeks to continue treatment. Again, that is not so bad in the short term, but maybe several months to years out, it may be best to give the person options to come off of that medication. But that may not be for everybody either. So there are financial incentives to keep people on MAT for as long as possible. And there's researchers directly profiting from more people being maintained on higher dosages of Suboxone. This graph shows why I have some skepticism about the routine recommendations and medication regimens that I've seen, keeping patients on 16 and sometimes even 24 milligrams of buprenorphine. While this graph is not uniform to every opioid user, it provides a guideline for how much protection you get at each dose of Suboxone and reveals that doses of 8 to 10 milligrams are pretty close to as protective against overdose as doses of 12 to 32 milligrams. Unfortunately, with Suboxone, that benefit maxes out around 12 to 16 milligrams of a total daily dose. But the side effects, most relevantly sedation and constipation, continue to increase as the dosage increases. So no more protection, but increased side effects. To me, the question is not Suboxone or no Suboxone. It is, how long should somebody be on Suboxone, again, if they're not willing to go the Vivitrol or the naltrexone route? The answer is nuanced. So the risk of death in those discontinuing their Suboxone within 3 months is reportedly pretty high, nearly 3 to 6 times the risk of those remaining on Suboxone, which makes sense based on how it works and the risk of fatal overdose without it. But there is not good and clear literature on longer-term risks and or how to best taper and maintain sobriety. It's very reasonable to keep somebody on Suboxone for 3 to 6 months, especially if they were previously injecting heroin or fentanyl directly into their bloodstream. And this measure can be very effective at reducing harm. Ideally, we would get more people to transition to the long-acting antagonist Vivitrol. But this is not highly desirable to patients who must go through the withdrawal process in order to take Vivitrol. There's also a significant protective effect of buprenorphine at lower doses. Prolonged tapers after long periods of sobriety with reinitiation or re-increase of the dose, if the patient uses, are very reasonable options. I would never force somebody off of their Suboxone or try to pigeonhole them into one form of treatment. But the reality is that this is a $14+ billion market globally. And keeping people in supportive community and social programs without Suboxone is not nearly as lucrative. As with most things in American medicine, we've got to prioritize the patient's progress over the financial incentives of the company or companies that create and distribute these tools. And we've got to individualize our treatment to each specific patient, taking into account their goals of treatment. In summary, Suboxone is a novel and very safe MAT option that is important in preventing people from dying while in especially the initial throes of addiction and recovery. It's not a zero risk, but it is so much damn safer than methadone. And if people are diverting it to the street, which has been a thing that I've heard several times in the last decade about Suboxone, who cares? It blocks the effects of stronger opioids like fentanyl. It may be saving lives whether it's prescribed or not. And, by the way, people who use or inject drugs, the vast majority of them know what the effects of Suboxone are. Based on illicit users' reports, they're typically trying to self-treat. And maybe they're not willing, and I don't blame them, to engage or intersect with the healthcare system for some of the reasons that I've mentioned before on this podcast and in the last couple of slides. They maybe fear the system will take advantage of their strife. People need to be given options. Suboxone is not without risks, and it's not without business persons, including the U.S. government having a stake in Suboxone, and providers with ulterior motives promoting routine visits to clinics that kind of start to look awfully similar to the OxyContin pill mills that started this mess in the first place. Patients who decide to start on Suboxone should be given options at every encounter. It should be a shared decision-making process, and like with most psychiatric drugs, there should be long-term taper options when they start feeling more comfortable in their addictions, and they should be counseled to not just abruptly stop taking Suboxone, go into severe withdrawal, and then much more likely at that stage to seek out an illicit opiate. So I had to put a couple of slides on this. This is one of my pet peeves in psychiatry and especially in addiction treatment. Probably the reason why I'm having a hard time remaining employed at multiple different profit for-profit addiction facilities or companies. It's my reticence to engage in polypharmacy and maybe my outright attacks on how polypharmacy is not helping our patients. More simply stated, I'm not trying to replace an addiction to illicit substances with an addiction to a bunch of prescribed substances. So at many of these addiction treatment facilities, especially seemingly in my area, patients have many withdrawal-related complaints. And the answer too often is to medicate away every aspect of withdrawal. Again, we've got to ride a moderate line with this. This doesn't allow the patient to experience some of the needed discomfort of withdrawal, which should be emphasized as an important part of the healing process. But it also puts them directly in danger, sometimes in more danger acutely than the illicit drug did. Regularly, patients are met at the door of the treatment facility with a long list of withdrawal medications, paired with any home medications that looks to be a mile long. I shit you not, I have seen dozens of patients with psych-only prescription drug regimens, including 10 different psychotropic medications. This is not effective treatment. There are all kinds of articles, research, and information about the harms of polypharmacy in general, which are magnified in the population using illicit substances. You can be the best pharmacologist, the best psychopharmacologist in the world, and there's no way you can understand and predict every different drug-drug interaction when you start getting into that many medications. This is an actual medication regimen that I came into one day while working in southern Indiana at a facility that provides addiction treatment, inpatient. I wish I could say this was the exception, but it seemed that 20 to 40% of the patient population was coming in on at least 5 psychiatric medications. Or was by the time they were discharged was on at least 5 psychiatric medications. On admission, there was what I call idiot medicine, idiot addiction medicine, idiot psychiatry, whatever you want to call it, being practiced, where lazy practitioners followed company guidelines or policy when they got an admission call, starting every PRN or as-needed medication without even looking at the characteristics of each individual admission. I'm talking about starting ibuprofen on somebody with kidney failure or not a fully functioning kidney. I'm talking about somebody who's got liver enzymes severely elevated and starting them on Tylenol for pain relief. Just clicking a button instead of looking at the characteristics of each individual admission, including their age and medical comorbidities, whether they're actually taking the medications they say they're taking by looking at a pharmacy fill record, looking at what drugs, illicit drugs they've recently used and thinking whether or not any of that is still in their system, aka not critically thinking for 1 second about not just the short-term implications, but also the long-term implications of these polypharmacy regimens. One day, I came in to find an older woman coming off of fentanyl, OxyContin pain pills containing fentanyl illicitly, for less than 24 hours, having been given multiple sedative hypnotics, along with multiple other psychotropic drugs. And at the time when I saw her at first, she was confined to a wheelchair. She was unable to participate in an interview with me. Her blood pressures were dropping below 80. She was nodding out. So she actually ended up having to get a little bit extra evaluation. Within a few days of significantly reducing this polypharmacy regimen, she was able to participate in the program. She was able to walk without any sort of ambulatory aid. She was a completely different person. Let's look at one of the reasons why we cannot be so cavalier in treating every symptom a person struggling with addiction and recovery complains of while they're in withdrawal. And by the way, please resist the urge to think that I'm saying no drugs should be used in treating symptoms of withdrawal. I'm just pleading with providers and companies employing them to think about the potential harm they're doing with these protocols and procedures that lead to short-term avoidance of discomfort, and also probably lead to improvement in patient satisfaction scores while they're at the facility. This is not at all a comprehensive list of what are called CYP interactions. This just shows the ones involving psychiatric drugs. CYP is a set of liver enzymes that helps to metabolize drugs and substances. As you can see, there are drugs that inhibit and induce the metabolism of different substrates. If somebody uses fentanyl, which is, as you can see here, metabolized by CYP3A4, and they are also on Paxil, or they are on Prozac, or certain antibiotics, or certain antifungal treatments, relatively common for people seeking help with their addictions. If they have any sort of STD, or I've had multiple patients with fungal infections, that may prevent that person's liver from being able to detoxify the fentanyl, and they may also have damage to their liver coming in already. This can lead to a buildup and a much greater risk of death from respiratory depression. Alternatively, other opiates may build up with co-administration of more commonly known meds, like, again, Prozac, Wellbutrin or bupropion, hydroxyzine or Vistaril, often used to treat acute anxiety, or antivirals like ritonavir in HIV treatment, which again is much more prevalent in this community than the general population. We cannot help somebody in their recovery if we kill them via overtreatment during their withdrawal. Now, not only does this polypharmacy approach carry significant short-term risks, it's also in direct opposition to one of the fundamental psychological problems or root cause of addiction. The focus on relieving or moving away from short-term discomfort at the expense of moving towards things that are important and meaningful to the person in the long term. I try to show this to every patient who's in a position to hear it early in their recovery. You can break down this chart. The bottom is the internal experience. The top is the external experience. Moving to the right is things that the person does behavior-wise moving towards what's important to them. And moving to the left is things behavior-wise the person does moving away from things that are uncomfortable to them. Addiction starts in the bottom left corner. It starts with the mind and that animal brain part of us that makes us experience intrusive thoughts or emotional reactions to things that can be unpleasant or unwanted. We don't have control over making these things go away. They insert into our stream of consciousness without asking. This can easily lead to a natural and reactionary behavior of getting away from that internal discomfort via external means, such as using drugs or alcohol. Again, this is not just limited to drugs and alcohol. This is something we all struggle with to some degree. It may be your phone. It may be a video game. Maybe it's work, with obviously varying degrees of complications that can occur based on whatever it is you're using externally to avoid. But it is a struggle with our internal experience or our mind. Fundamentally, we're dealing with the same problem. We can find ourselves living in a cycle of avoidance on the left side of this graph. We need to emphasize how to hack into and better understand our own minds in our approach to addiction, taking intrusive thoughts and emotions and stripping them of their content, and instead trying to understand why we have those thoughts or feelings or emotions. What is the intention behind them, as opposed to hyper-focusing on what is said or felt, to help that more conscious frontal lobe part of us use those intrusive thoughts, feelings, and emotions to have a better idea of What is important to me, to us internally? What do we value in different facets of life? And then and only then use those values in the bottom right corner to guide our specific goals or actions. Withdrawal is a microcosm of that very idea. And people fighting addiction need to understand it is a fight. We need to find ways to embrace some short-term discomfort in the journey so that we can promote long-term stability and meaningful living. So we've got to do a better job of tailoring treatment to more specific populations within substance use disorders and meeting people where they're at, individualizing treatment. There is no one cookie cutter approach to treating addiction. It is a super complex, multifactorial disease. The person's biologic or genetic profile, including underlying mental illnesses or factors that affect their intellectual functioning or their ability to communicate effectively. It includes past life experiences, commonly trauma in the substance use populations. And some of the traumas, people can't even imagine what somebody who is struggling with heroin addiction, some of the things that they've been through in life. So many of us just don't get it. And we may not even be in the position they're in if we had gone through those same things. We're talking about current social influences that have to be taken into account in formulating treatment plans. This chart separates patients struggling with addiction into 3 overarching categories. Those not seeking care, with treatment recommendations focusing on harm reduction and safer use. Those seeking out care to help reduce their use or find alternatives to using. And active users trying for control via medication-assisted treatment or abstinence. There's no stigmatization in this chart for those not wanting to get sober. But this is a great example of treatment meeting users where they're at and taking their treatment goals into account. Sometimes users in the throes of addiction, and also sometimes just people in general who have experienced traumatic upbringings or experiences, can be rude and downright nasty. Our job is to not be offended, not take it personally, but to find the right column and try to help them engage in treatment in whatever way they're willing to do so. So these are just a few ways to start to stem the tide of the drug epidemic in this country. Ultimately, I think these are other critically important aspects of our overall approach to addiction. This series is trying to decrease stigma, trying to increase awareness of just how bad this problem is, and also educate users as well as the general public in order to prevent harm from occurring. It's so important that we start holding pharmaceutical companies, distributors, pharmacies, physicians publicly accountable for their poor, financially motivated choices, as too often, including with Purdue Pharma, as well as the makers of SSRI antidepressants, these companies, when faced with a lawsuit for a bad outcome or outcomes, force plaintiffs to sign NDAs or non-disclosure agreements as a prerequisite for getting their settlement money. This is done separate or independently from the legal system. It prevents the general public from having access to the details of those cases. If we, the American public, knew more of the details, more people would be up in arms over these harms related to prescription drugs. Mental health providers also cannot do this alone. And due to the high incidence of medical problems in this population, there has to be a collaborative care approach involving not just medical care, but adequate and nuanced medical care, social and psychological services, access to housing, work, community. All of these things have to come together to give people the best chance at meaningful recovery. So a couple of last thoughts, ideas. Something I personally believe is long overdue, if we want to get a better grasp on this problem, is to legalize and regulate all drugs. Look, we're losing this so-called war on drugs. Well, the private prison system is winning, while the American people take all the losses. We're not able to prevent illicit drugs from coming into the country, and we haven't been able to do that effectively for the last 40 years. The DARE program that I grew up with, bringing cops into schools to try to scare people into not using drugs, telling people to just say no, did not work. With all kinds of evidence, most notably the obvious drug epidemic numbers continuing to rise and become astronomical, prove that it didn't work. By the way, DARE was started in LA by Daryl Gates, the chief of police, who in 1990 once said, "Casual drug users should be taken out and shot." Needless to say, this is not a very humane approach. It reminds me of the abstinence-only approach to sex education. Instead of teaching young people about safe sex, that abstinence-only approach, by the way, also didn't work. So we're not stopping the influx. We're not curbing the desire for people to experiment or escape to or use drugs. So to me, that leaves legalizing and regulating drugs. That way, people can access drugs they are seeking out without the risk of them being contaminated with fentanyl or other non-desired substances. They can be educated about the drug they're using, including its short-term and long-term effects, instead of incarcerated and demonized for daring to go against the abstinent-only approach. As you can see with Portugal, which decriminalized all drugs in 2001, their number of overdose deaths, new HIV diagnoses, and people incarcerated for drug-related offenses have all dropped drastically between 1999 and 2017. Portugal is now joined by Czechia, the Netherlands, and Switzerland among a handful of countries that have decriminalized drug use and possession for personal use and heavily invested in harm reduction programs. And these countries are having consistently good results. Now, what I will say, again, appreciating the nuance, marijuana provides a little bit of a cautionary tale about legalization. So many of our drugs, licit and illicit, are adulterated, which is a process that specifically means reducing purity. But in this context, the natural marijuana plant is adulterated by taking the psychoactive compound, THC, which naturally occurs, again, in the organic, natural plant that grows in nature, in 1 to 3% of non-manipulated marijuana plants. And using that psychoactive vegetative part of the same plant, but cultivating excessive and unnatural amounts, taking out that 1 to 3% and cloning it to create what we see in our medicinal and recreational marijuana today, THC concentrations of 15 to 100%. By the way, just as a public service announcement to people who smoke weed, stop using marijuana vapes. They are on average nearly 100% potent. They started out in 2005 around 5% potency on average, and it did not take long for the average potency today to approach 100%. Smoking the same amount of a 100% potent substance versus the historically 2% potent substance simply cannot be good for your brain. And by the way, most of the medicinal benefit of marijuana is related to CBD. Look, we've got to do something differently with how we treat addiction. We just have to, or we won't get out of the rut that we're in currently. Primarily, this novel approach involves having compassion and providing support for people using drugs, trying to understand why they use drugs before dictating how they need to be treated for it, offering several different treatment options, as we do for other chronic diseases, that are tailored to the specific person standing or sitting in front of you, and stop letting fear of people who use get in the way of a treatment that the majority of Americans need access to or need to help their loved ones get access to. Hopefully, this series has been eye-opening and viewers or listeners take away a better understanding of the overall impact and need for change in addressing the drug epidemic. If not, we may see numbers and afflicted persons continue to rise well above the already crazy numbers we see now, with over 100,000 people dying in a matter of minutes from overdoses every year, and millions more suffering from long-term complications such as HIV, hepatitis C, endocarditis, other infections, sexually transmitted diseases, depression and suicide, psychosis and other worsening mental health problems, lung failure, liver failure, kidney failure, heart failure, vascular complications, high blood pressure, stroke, headaches, loss of productivity and meaningful living, child abuse and neglect, neonatal abstinence syndrome, users being separated from their kids, sometimes solely because they failed a drug test, kids not having appropriate role models to look up to and raise them into adulthood, overcrowded jails and hospitals, domestic violence and murder, violent crimes. The list goes on and on and on. It's sad, but we've got to maintain hope that we can dig ourselves out of this hole by doing things differently. Part of that hope is changing the way that we approach it. I hope that you've enjoyed. I thank you for watching and listening to me rant on America's current and ongoing #1 public health crisis. The last few slides are an incomplete list of source material for these overdosed PowerPoint presentations. I started to give presentations on this nearly 10 years ago, and my understanding and hence the PowerPoints have been updated multiple times since then. I have several other sources embedded in my internet browser. And if you're interested in having direct access to all of the data I'm referencing here, please reach out directly via renegadepsych@gmail.com or via the comments section on YouTube if you have other questions, comments, concerns, suggestions. Thanks again for listening. Like this video, like this series of videos, subscribe, all those things that will help to spread the word and promote the message. Thanks. Thanks again for watching and or listening. If you're passionate about the subjects that I discuss on the channel, do me a favor and like, comment, subscribe, do whatever you can to make your voice heard, that these are problems that must be addressed in our society. If you have any questions, comments, or concerns, I want to hear them. Feel free to reach out on social media or email us at renegadepsych@gmail.com. And if you'd like to be a guest of the show, or you have a connection to somebody that you think would be a good guest, let us know. Thanks again for listening.
Disclaimer. This podcast is for informational purposes only. The information provided in this podcast and related materials are meant only to educate. This information is not intended as a substitute for professional medical advice. While I am a medical doctor and many of my guests have extensive medical training and experience, nothing stated in this podcast nor materials related to this podcast, including recommended websites, texts, graphics, images, or any other materials, should be treated as a substitute for professional, medical, or psychological advice, diagnosis, or treatment. All listeners should consult with a medical professional, licensed mental health provider, or other healthcare provider if seeking medical advice, diagnosis, or treatment.